I'm Stephen Morrissey, managing editor of the New England Journal of Medicine, and I'm talking with Timothy Quill, a professor of medicine, psychiatry, and medical humanities, and the director of the Center for Ethics, Humanities, and Palliative Care at the University of Rochester School of Medicine and Dentistry. Dr. Quill has co-authored a perspective article on balancing evidence-based medicine with patient-centered care. Dr. Quill, in your article, you outline a 5-step process for clinical decision-making that involves integrating and weighing input from the literature, the patient and family, and treating clinicians. In your experience, how often do physicians follow that type of process?
I think we've gotten much better at weighing medical evidence and trying to figure out what large studies mean for particular people. So I think we've learned how to do that. And in a separate strain, we've also learned that patients really are the ones who are going to have to make decisions. I think where we've had more trouble is trying to figure out how to meld those two strains so that we often are very paternalistic on complex medical decisions using medical evidence on the one hand, and on the other we may be making patients make decisions that are out of their depth or without a great deal of guidance from us. So this article was really about trying to meld those two strains to help people really make good decisions in tough circumstances.
Where do you think clinicians and, I suppose, patients to some extent too, tend to fall short today?
Well, I think, again, what they do is they scratch the surface of this process but don't get into it deeply enough sometimes, so that they might hear what the evidence is and hear a recommendation from a doctor, or the patient might say, yes, that sounds good, or no, it doesn't sound good, but that ends the process. And what you really want to have happen is to have them have a real exchange around these issues so that the patient's reluctance gets explored or the doctor's recommendation gets explored so that they really do understand one another, so that you really use evidence and preferences to make decisions rather than letting one or the other dominate.
Do you think that the time that would require is going to be available?
I don't think it's that time-consuming. I think it really just is a matter of hanging in there and going a little deeper at these critical moments. These decisions are just tremendously important, particularly some of the bigger ones. But it also applies on smaller decisions. But big decisions, we ought to probably be spending a little more time up front before we get into some of these large medical adventures. And people are beginning to learn that. They're beginning to say, when I'm reluctant, let's sit down and talk. Let's maybe have somebody else talk with the patient. I think that's on the right track.
In fact, the case you use as an example involves a big decision. It's end-of-life care. Are there other healthcare decisions that you think the process could be useful in?
Yeah, there are many. It's certainly not just for end-of-life care. And in fact, the case that we're talking about might be end-of-life, but it might not, depending on how it unfolded. But I think when there is, for example, on the serious end of the spectrum, risky surgery, where there's a risk of moving forward with surgery and a risk of holding back. We just saw a patient who had a big aneurysm, but he also had multiple other aneurysms and medical problems, and he had to balance the risk of going for surgery right now versus watching this aneurysm for another 6 months to a year. So these are very tough decisions of taking a risk now versus the risk of waiting, and this requires really some really in-depth conversation so that he understands both sides of this equation, and his view about these kinds of things has got to be given a lot of weight, because there's no risk-free way to go. In this particular patient, the risk of not going forward it was going to drive him crazy, so he was really willing to roll the dice. But this also applies to circumstances of kind of more routine things. Take the prostate cancer screening question, which actually, is quite a complex question when you get into it. The data really don't support doing this kind of screening for most patients, but there's not a risk-free way to go forward. So this does require some conversation, some notion of the patient's values, and some thinking through the consequences in both directions. So it applies to routine practice as well.
that learning about the patient's goals and values is a key part of your process. In a companion perspective article, Lamas and Rosenbaum describe residents asking patients very specific questions about interventions that most patients aren't in a position to make decisions about. What's an appropriate way to lead a discussion that gets you to the patient's goals without placing too big a burden on them?
Well, I think you do sometimes see doctors asking patients around sort of some of the technical aspects. Do you want a central line? Do you want this drug or that drug? Clearly that, for most patients, doesn't make a great deal of sense. So you're really talking about having a discussion about the overall goals, what the overall approach is going to be. Do you want to take a really aggressive approach, which is going to require certain kinds of things, and here's the pluses and minuses, and then have that conversation, but then probably not involve them in the details of how that's carried out, because that's just that's too much. There are a small number of patients, of course, who want to get into that level of detail and who need to hear about everything, and that is time-consuming. But those folks are the exception rather than the rule, and that's really not what this is talking about. This is about sort of finding out this direction is likely to take us this way based on evidence, that choice is going to take us that way, and then you have a conversation about the patient's values with regard to those two general directions. And then once the general direction is decided upon, then really clinicians should be given, in most cases, pretty free rein to make the micro decisions around the overarching direction.
As you say in your article, these decisions can be emotionally charged, and you recommend that clinicians modulate their tone, balance hope with realism. It's clearly an art. Is this something that can be taught?
I would say it can definitely be taught. Certainly the emotion, how do you take the emotion out of it or modulate it to some degree? These are skills like any other skill in medicine. And some of the so-called emotion management skills, such as acknowledging the emotion, you seem to be scared, you seem to be sad, legitimating, anybody faced with such a decision would feel this way, and then really trying to get patients to explore the underlying thinking that's leading to this emotion so that the doctor really understands that these are skills that even somebody who doesn't have a lot of emotional intelligence can carry out as a physician. So I think those are skills that we teach our medical students and work with them and try to reinforce that they can do it. There's also the notion of either-or thinking. So if you're trying to be hopeful and taking some long-shot treatment, we also encourage people to prepare in case that doesn't work, so that it's not putting all the eggs in one basket. You're really going to try to teach people to both think about one direction but also prepare in case that doesn't work. And I think these are things that can be taught.
And then in terms of putting them into practice, do you think it should be residents or attending physicians who are actually carrying out these conversations?
Well, I think with my hat on as an educator, I would say that these responsibility for these decisions and discussions should be incremental. So clearly, I don't think medical students are going to be involved in a lot of these deeper discussions about moving forward. They certainly may observe them, they may participate, they may help people figure out after the discussion has been initiated. But I do think as residents, they start to have decisions around CPR and do not resuscitate. And I think that's a discussion that has these characteristics. There's evidence about how likely it is to work in certain circumstances. It's emotionally charged to make a DNR decision. So you have to get into patients' preferences, and some patients may initially want full code because they're so afraid of letting go of that, or they're afraid the doctors will give up on them. But as you explore that with them, they really don't want certain kinds of things. So that's very amenable to this dynamic. And I think those are the kinds of conversations that our residents should be involved in. I think ideally we would observe them doing these discussions, because there are ways to do it and ways not to do it, so that it can be very doctor-dominated. I'm going to get the DNR, or it can be very patient-centered. Do you want me to resuscitate your mother? And that's patient-centered only in the most superficial way, because if they say yes, you really want to have more conversation about that and make your recommendations and have a deeper discussion so they get at what's really the right thing to do in that circumstance. Then with these things like the case we brought up in this perspectives piece, where you have to have a lot of clinical experience just to understand what the stakes are and what the risks and benefits are, I think that requires a higher level of training and experience to have those conversations.
There's been a lot of attention lately to the cost of care and whether physicians and patients should be including cost in the equation when they make major decisions about their health care. Do you think cost should be considered? And if so, how would that affect your process?
Well, I think cost should be considered, but I'm not sure this is the right place to be considering it. Clearly, that's at the most important level to have that discussion is at a policy and public level, and we are clearly reluctant as a society to have that discussion until it's really going to hit us over the head, which it seems to be. If it isn't doing it now, it's going to be in the near future. I think costs are a tougher thing to put into this individual patient discussion. So there are costs, there may be out-of-pocket costs that people have to pay for. Those are clearly relevant. There are certainly costs to psychologically and spiritually of intervening versus not intervening. But the economic costs, I think, are probably better left out of this discussion, at least right now, and keep it more in terms of the risks and benefits, both personally and to the family and those kinds of levels.
In the case you describe, an understanding of the patient's preferences resulted in the rejection of aggressive care of a ventricular assist device. Does your experience with patients suggest that more conservative or even palliative care would be chosen more often if clinicians followed this process and understood what patients valued and were looking for?
I would say sometimes yes and sometimes no. I do think as we get into more and more treatments with more burden and less gain, if people really are, my experience in palliative care is that if you really inform people about what's really at stake here, a fair number of people will set different limits than they will if they only understand it at the surface. Having said that, there will be a percentage of people who will take any risk to live a little bit longer, and we support that in palliative care. And again, in the current environment, that's a choice people can make. But you'd hate to have them make that decision based on false information or a lack of an in-depth understanding. And the more burdensome the treatment is, the more risk it has, the more you want people to really understand what they're getting into up front, if possible. That was what was the case that we presented in the article. This is serious treatment. This is not something to enter into lightly, a VAD or a major surgery. And if people have the right criteria and they understand what they're getting into in the current environment, then and they want to do it, that's okay. But they really should have a lot of conversation with these burdensome, high-risk treatments. Now, again, treatments like that, there's risk to going forward and risk to not going forward, so there's no risk-free approach. But you want people to understand as much as they can up front if possible.
Thank you, Dr. Quill.
My pleasure.